Good morning to all doctors participating in this webinar, and thank you for joining. We're so glad to see you again at 1 Hour with the Maestro webinar series. My name is Anastasia, and I'm going to guide this event. First of all, we would like to say thank you to Sabang Merauke Eye Center, Dr. Agarwal's Eye Hospital, Chendo, and Meiji for supporting this event. We're so excited to tell you that at this moment, we have near 1,400 participants from 85 countries and 6 continents around the world, streaming from Zoom and YouTube Live. Wow, so incredible. Thank you for the enthusiasm. The speaker in our webinar today is Professor Amar Agarwal, MS FRCS, FRC-OFF. He is a professor and head of Dr. Agarwal's Eye Hospital and Eye Research Center in Chennai, Tamil Nadu, India. And the moderator is Dr. Gede Pardianto from Sabang Merauke Eye Center, Medan, North Sumatra, Indonesia. This webinar will be divided into 2 sessions. The first session is an online course titled Phaco Nightmares and Glued IOL in Phakic and Sticky Situation. And the second session is the Q&A and discussion with the speaker. So if you have any question, please feel free to drop your question to Q&A chat box, and Professor Amar will answer your question on the second session. Before we begin this webinar, please pay attention to Indonesian National Anthem. Attention please, Indian National Anthem.
गाहे तव जय
We will start the first session of this webinar. Dr. Gede Pardianto, the time is yours.
All right. Thank you so much, Ruth. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Indonesia. Good morning, India. Good morning, Amar. Good day and happy holiday to our friends from all the rest of the world. It must be afternoon in Pacific, Australia and New Zealand, morning in Asia and Middle East, dawn right now in Europe and Africa, midnight and night in North America, Central America, and South America. Welcome to this international webinar that is attended by more than 1,400 participants from 85 countries, 85 countries of 6 continents around the globe. Welcome to our program, 1 Hour with the Maestro. Thank you for joining. I am Gede Pardianto, and this is Dr. Diah Purwarini. She was speaker in ACRS Singapore, presenter in WUOC Tokyo, and Marrakesh, Morocco, author in Indian Medical Journal, judge in Asia Pacific Conference of Young Scientists, twice in New Delhi, India, in Kathmandu, Nepal, judge at World Tournament of Champions at Yale University, New Haven, Connecticut, USA, twice in 2018 and 2019. She has her name on the official site of NASA. She is supervisor of space research collaboration among Chandra Kumala School Indonesia, CIL Indonesia, West Institute California, Northrop Grumman Corporation, International Space Station, wow, International Space Station, and National Aeronautical and Space Agency, NASA, USA. Their work has been presented at American Society of Gravitational and Space Research in Maryland, USA, 2018. Wow, what's a woman? That is really awesome. This morning she will be my interpreter in case I become lost in translation. Yeah. So ladies and gentlemen, the maestro this morning will be Dr. Amar Agarwal, a legend, a guru, my old friend, professor and head of Agarwal Eye Hospital and Research Center, Chennai, India, winner of Baraker Medal, wow, Kalman Medal, and numerous awards of ASCRS, AAO, and ESCRS Film Festival, and he has written more than 50 books, and many of which have been published in multiple languages. Wow, that is awesome. At this moment, he will present a very interesting topic with the title Phaco Nightmare and Glue IOL in Sticky Condition. Very cool topic. Now, we are learning from the man who has many years experience in this procedure. This procedure is excellent to handle super challenging, unwanted situation during cataract surgery. We learn how to be calm, how to do the right things whenever a 5-minute planned surgery becomes a long, stressful nightmare. So please pay attention to Professor Amar's lecture. Thus all our ultimate attention to perform all maneuver to save the day, to save our patient, and to save our practice. Fellow ophthalmologists, let's pay attention to Professor Amar Agarwal. Amar, India has space program, right?
Yes.
Amar?
Yes, can you? Thank you so much.
4, 3, 2, 1. Time is yours, Amar. And live off. Give applause to Amar Agarwal.
Thank you very much, first of all, to entire Indonesia and also to all the 1,400 delegates watching from 85 countries. I have to thank Gede and to Ruth, who have been working with me for so long to prepare this whole system there. I'll start sharing my screen now. Okay. Desktop. And let me ask you if my video comes on now.
Yeah, it's coming.
Yes. We
Believe it's us.
Is it full screen?
Full screen, yes.
now, yes, now it has been full screen, Professor.
Okay, lovely. So I'll be starting now. The first case which I wanted to show you is this. Now, this is a case of Marfan syndrome. I'm going to start from basics and then I'll take it slightly higher and to more difficult situations. Okay. Now, if you see here, basically in this particular case, and you can hear me well?
Yes, Professor.
So what I want to show you here is, look at this case now. In these cases, these are progressive conditions. The problem in these progressive conditions is this, that if you do, let's say, an endocapsular ring, 10 years down the road, this will lie on the retina. So these cases, you are much better off doing something like an intrascleral haptic fixation. Now, if you notice, I fixed two flaps, which are 180 degrees apart. These flaps, I used an epsilon marker to track it. Always have fluid in the eye. Once you have fluid in the eye, you can see I fixed a trocar cannula on the top here, there. Okay. And the basic idea there is this, that with this trocar infusion cannula, I have fluid in the eye. Now my second step is I made my incision a little bit. And now what I'm going to do is I'm going to do a lensectomy vitrectomy. So I'm taking my vitrectomy probe. I'm doing a little bit of lensectomy, as you can see there. And with that, vitrectomy. This is a young boy. Now, the problem in these cases is the eye is large. Remember that it's white to white is more than 11 millimeters. If it is, I make a small iridectomy near the scleral flaps. You see, I'm making that flap there and I'm making a small iridectomy, and you can see that iridectomy there. Why am I making this iridectomy? Now I can come more anterior with a 22 gauge anterior sclerotomy. And you can see there, once I made that, you can see I'm making that small anterior sclerotomy. Then I do my lensectomy, clear it up here fully. And as you can see there, I'm continuing removing the lens there. Now, once I have done this fully, remember I have made one side anterior sclerotomy. I also have to do on the other side. So for that, again, I'm going to make a small iridectomy. Here you can see I'm going to now do this iridectomy. Why am I doing the iridectomy? Please understand, I repeat, because I want to come more anteriorly. Once I come more anteriorly, I'll have more haptic externalized. So that's why I'm making the small iridectomy. Now you can see once the iridectomy has been done, I made my sclerotomy which goes through the iris. If I did not do the iridectomy, I will damage that iris. So now, once that's done, my next step is I will now go in and implant my IOL. You can use any 3-piece IOL of your choice. But the lens I prefer to use, and I suggest people, is use the AMO or the J&J lens because it's very sturdy. The Zeiss is good, but it's not available anywhere except in the United States. Now watch carefully. The haptic is a little bit out of the cartridge. Once that's there, I catch and I'm now injecting it continuously. So you can see there, once the lens is come out, I will now externalize the first haptic. You can see the first haptic out. Now, watch the second portion. I'm going to now flex the second haptic. Now I pass the glued IOL forceps through the side port, transfer it to the other hand. Now take the first hand through the sclerotomy, going through the iris, catching the tip of the haptic. Now you can see both haptics are externalized. Now watch carefully. The amount of haptic externalized you can see is a lot. That means this lens, when it is tucked and glued, will never come out. So you can see now there, I'm now going to create this tuck there with a 26 gauge needle. Remember, your first entry was with a 22 gauge needle. The tucking or the needle haptic creation with a chariot's pocket, I'm creating with a 26 gauge needle. All I do is take this haptic, tuck it inside. And you can see once that is tucked, the second haptic also, I've created that pocket and I am tucking it inside. Now check, you have come anteriorly. So do you have any optic capture? If there is, you should do a pupilloplasty, but look carefully. There is no optic capture in this case, and that means this case is completed. Now look how nice the case looks when it's completed. Put in a little bit of air. All I do is take out my trocar, and the next step, all I have to do is apply the fibrin glue and seal this patient down. And this patient improves to 6/6 vision. So you can see now I have completed this particular case. Now let's see if I can make this difficulty slightly more. And I hope you're seeing my video now. You're seeing the video, Ruth? Okay.
Yes,
We can
Professor.
see it, Professor.
Yeah.
Now look at this. Let's take this difficulty slightly more. This patient was a VIP patient who flew 3-hour flight. He wanted to get no glasses. Now look at the case. Subluxated cataract. Now the mistake I did in this case was I fixed an endocapsular ring. Now when I fixed my endocapsular ring, I did not have at that time a Sioni ring. That was the first mistake I did. Then I just continued the surgery. And look at that. I have a rent, and with that, gone. Nucleus gone down. Now look at my mess. Remember, VIP patient comes all the way, and I'm telling him, okay, I'll make you all right. And what do I land up with? Is a PC rupture with a nucleus drop. Now, I can get that endocapsular ring going down. So before it goes down further, I'm going to catch that endocapsular ring, bring it out. Otherwise, I will have an intraocular foreign body, which is an endocapsular ring. Now look at that bulb of vitreous which is present there. I make my scleral flaps. I inject triamcinolone. When I inject triamcinolone, I'm now going to clear up everything there so that if there is any vitreous present, it will be removed. Now look at that fragment which is there. I do a posterior vitrectomy, and now I'm going to remove that fragment. So you can see there, I'm knocking off that fragment present there. Now I take my lens. Now, the AMO or the J&J have got a multi-piece multifocal IOL. That is a 3-piece multifocal IOL. They're the only company who have it. So you can use this lens. I'm taking the haptic inside. Now what I'll do is, I'm going to catch the haptic, externalize the first haptic. You can see with the handshake technique there. Once the first haptic is out, I will now externalize my second haptic. So what am I trying to do, ladies and gentlemen, is I'm trying to create a multifocal glued IOL. The advantage in this is I can fix the rings where I want. Look, I can fix it, tuck as much as I want on one side, untuck on one side, but the game plan is my lens will be bang centered where I want it. And this is a multifocal glued IOL. Now look at another case. This was another VIP patient who had been operated elsewhere, and he was referred to me by a top ophthalmologist. Okay, and look at this. What happened is, what I saw was, I saw part of the lens only. So I thought, let's fix this lens which has been dislocated. I fixed my trocar AC maintainer. Look at the trocar. This trocar is going through sclera. But remember, the cannula is above the iris. This is 0.5 millimeter from the sclera only. So the advantage for an anterior segment surgeon is, if you use a trocar AC maintainer, all you need to do is fix it. I'm not worried now whether it's going into the subretinal space or not. Now, all I do is, I make my small iridectomy. Look at that iridectomy I'm making, because again, this is a large eye. Any eye, wide to wide, more than 11 millimeters, make a small iridectomy so that you will have more haptic externalized, because I can come more anterior. Now I can't see because the pupil is small. So all I'm going to do is dilate it with iris hooks. So what I see now is a multifocal IOL, which is decentered. So I'm catching that. Now my idea is, I'm not going to explant this IOL. The same IOL, I will refixate. So I catch the haptic. Now you see I catch, again catch, again catch. I'm moving it slowly. This is the handshake technique because I want to catch the tip of the haptic. Once the tip is caught, I will now pull it out. Now you can see there, I pulled out the haptic there. Once the first haptic is out, now I do the same for the second haptic. Again, catch the tip of the haptic and pull out. So now you can see my second haptic also out. Now look, what am I doing? The same decentered multifocal IOL, I am going to glue it back in. Look at the amount of haptic externalized. It's a lot. So all I do is create the chariot's pocket like I showed you before and fix it. But look at this case. There is an optic capture. Once you have an optic capture on table, I do this technique called the single pass 4-throw pupilloplasty, which was started by, with the help of I have to mention the name of Dr. Priya Narang also at this stage, who helped on publish this and work on this technique. Now in this, I'm passing the needle from one end. From the other side, I'm catching it. And now I'm going to pass a 30 gauge needle. Remember, one side you have a paracentesis. This is where the 30 gauge needle is. Now all I do is railroad the two. Look, bring this loop out. This is a single pass. Now pass it 4 times. Once you have passed it 4 times, that's all I do. So this is single pass 4-throw pupilloplasty, and then you seal everything down with the glue. So this shows another case which I thought I will show you just now on how you are doing this particular technique. Since I brought in this technique, what I wanted to show you is, let me show you at this stage something very important. How to do this single pass 4-throw pupilloplasty. So just see this in a second. In this particular technique, if you notice, the first step, which I'll just show you in a second here, is when you are learning this single pass 4-throw pupilloplasty, see this. Take a proline needle. You can take a 9-0 or a 10-0. Pass it through the iris. Remember, there is no paracentesis on this side. Through cornea, through the iris, goes inside. Now from the other side, catch. Now take a 30 gauge needle, use a paracentesis, pass it inside and railroad the two. Once that's done, you can see now I'm going to bring this loop out. Once the loop is out, I will now pass it 4 times. See, 1, 2, 3, 4. That's all you do. See how simple it is. Anybody watching this can do this immediately when you go back to the operation theater. Pull both ends. See, normally what you do is you do a 3-2-1 throw or a 3-2-2 throw or something like that. Here you've done just once, 4 times. That's all. Now take a micro scissor and cut it. Once that's done, now you do one thing, do the same on the other side. That's it. So now let's look at how to do this single pass 4-throw pupilloplasty in different cases. Look at this case. This is a case of a Urey-Zavaria syndrome where the pupil is dilated. I fix fluid in the eye. Now I'm taking off that bubble. Now my next step is I catch this like that, iris there. Once I've caught the iris, I pass my needle. See, the proline needle goes through and through. Once it goes through and through, on the other side, I take a 30 gauge needle, pass it inside through the paracentesis. Remember, you don't need 2 paracentesis. You need a paracentesis only on one side where the 30 gauge needle or a 26 gauge needle is being used. Railroad the two, bring it out. Once that's out, you can see now what I'm going to do is bring this loop. Now, once I bring this loop to the center, I'm going to catch this loop and bring it out. Now, remember the number 4. I'm going to pass it 4 times. Once it is passed 4 times, that's it. You can see my case. Simple. The pupilloplasty is completed. Here you have done one side one. Now I'm doing the other side, the same story. And you can see how the pupil is looking very well centered. Now, once you have done that, look at this second case. This patient is a patient with penetrating keratoplasty, but look at the anterior segment OCT. The closed angles are there. Look how these patients will have high intraocular pressure. If you do a trab or you do a valve, that's the only alternative. But instead of that, I will tell you when you're having a closed angle glaucoma like this, how to solve the problem. Very simple. What we are going to do is, we are going to do a 4th-row pupiloplasty, and we are going to open the angles. See that? I'm going to pull on that iris and open the angle. That way, the fluid flow will come through very nicely and clearly. So now you see, I'm making a closed angle into an open angle. So now let's see how this procedure is done. You can have 3-point fixation, 4-point fixation, anything you want, depending upon how bad the case is. Now, once I've done that, look at this. I'm passing my suture inside through the clear cornea incision. On the other side, I've got the 30-gauge needle. I bring my loop out. Keep fluid in the eye all the time. I don't do this with viscoelastic. You can do it with viscoelastic, but I prefer to have fluid, because if some bleeding happens, the blood gets washed away. Now watch carefully. I'm going to pass it 4 times. Again, once I passed it 4 times, you see all I'll do is pull on it, and you can see my pupil coming down to normal. You have a lot of patients with penetrating keratoplasties, and look at the pre-op on top, anterior segment OCT here, and look at the one below. See the angle is opened, and look at the cornea, it has cleared, and look at the pressure, it has come down. How do you take this out? So now the preoperative vision was nothing much, hand movements, and now the post-op vision is about 624. So now let's look at another case. This is a patient with silicone oil, and there are retinal surgeons who are watching in this presentation. There are patients with silicone oil in the eye. You remove the silicone oil, the intraocular pressure is still very high. So what is the problem? The problem is not only silicone oil. The problem is the silicone oil has pushed the iris front. The whole iris is stuck to the cornea. You have a peripheral anterior synechiae. Again, remember, I'm going to do the 4th-row pupiloplasty. Now look at the one on the top. It's closed on top, and it is open here, the angle. That's what I'm trying to show you. Look at the preoperative picture, how hazy the cornea is. Post-operative picture, the cornea has become clear. Question comes, after this, can I dilate? We published this in the 2017 issue of the JCRS. And if you see here again, look at the preoperative after dilatation. Look at the pictures. You can dilate a little bit. Even when you have a lot of pupiloplasty done, you can see the dilatation effect, so that fundus examination can be done. Can I combine it with glued IOL and PDEC? And I'll show you a video of this case next. But look at the preoperative picture and look at the postoperative picture. What did I do? I did a glued IOL, I did a PDEC, and I did 4th-row pupiloplasty in this case. And I'll come back to PDEC again subsequently. Look at another case. Patient has one eye, only eye of this patient. Okay? Failed PK. I have not changed the PK. I have done a PDEC in this graft, and look at the angle below here, opened. So I've done 4th-row pupiloplasty with PDEC, and that's the preoperative and postoperative picture. Another thing we should understand now is pinhole pupiloplasty. Now, when a patient has high astigmatism of, let's say, 8 diopters, 10 diopters, what do? It's very tough. They are not seeing. So what we do is, we are making the pupil 1.5 millimeters. Once you have made it, the patient will start having extended depth of focus. So you can see there, this is called pinhole pupiloplasty. Now, in this, basically, look at this patient. The patient had high astigmatism of 24 diopters. They are practically blind. Now, in this patient, when a patient has this much, you can do dark, you can do a pinhole IOL, but rather than that, there's a simple procedure. I am making a pinhole pupil, and look at that, preoperative and postoperative vision has improved from to 6 12 vision. And this is pinhole pupilloplasty. So this is a case of pinhole pupilloplasty. Now, next thing which I wanted to show you here is another case. And I'll just show you in a second now. This is the video of the patient which I showed you just previously about the photograph. So, but let's make this more difficult as I'm going to show you this case, and you'll realize how tough this case was. This was a patient who had been referred to me by a top ophthalmologist from Bombay, Dr. Natarajan, who's a top retinal surgeon there. This patient had been operated 6 times and was going to commit suicide because of this blindness. The patient had just gone in for a simple cataract surgery, developed PC rupture, IOL drop, everything. When I saw the patient, the whole cornea is white. So now what I'm going to do is I'm taking off this epithelium right now there. Once I take it off, even then I'm not seeing at all anything. So I'm going to now fix my trocar AC maintainer. Look, fluid is in the eye. Now I made my flaps. Now I make my incision. So you can see my sclerotomy being made there with a 22 gauge sclerotomy. Now I try to do my vitrectomy and I can see this membrane, which is the desmase endothelium complex, is so fibrotic and thick. I'm trying to remove it to see if I can see better. Now, as I'm trying to remove it, I realize it is now stuck to the iris. So I'm catching it now with one hand and I'm going to try to cut it with the other. So you can see there now, I'm taking it with one hand, cutting it with the other, and slowly and steadily removing it. Notice my assistant is carefully holding an endoeliminator in one hand so that I can see slightly better. Now, once I have done that, you can see there, I have removed this portion of this fibrotic tissue. Now, what do you see? I see something inside which is moving. And if you notice carefully, it's shining. It's like an intraocular lens. So now what I'm going to do now is I'm going to catch that lens somehow, somewhere. Once the haptic is caught, I'm now going to catch that haptic somewhere. I don't know where I'm catching it because even I'm not seeing if you're not seeing clearly. So I catch it somewhere because the media is so hazy. Transfer it from one hand to the other. Once it's done, catch the tip of the haptic and pull out. Once my one haptic is out, I'm safe. Now I'm going to do the same in the other hand also. So you can see now, once I have done this, I will now catch in the other hand. So I'm clearing up the vitreous there, the muck which is present there, and I want to catch the haptic somewhere. And you can see there, I'm catching it somewhere there. Caught it. Now again, understand, I go in with this forceps and I transfer it from one hand to the other. Catch it there. Now I move it from one hand to the other there, catch the tip of the haptic and pull it out. Now you see both haptics are out. So I've done the glued IOL portion. Now I'm able to do. Amount of haptic enlarged is externalized is quite a bit. All I need to do is tuck the haptics inside. Once both haptics are tucked, now look at my next problem. The pupil is large. So all I need to do is make this pupil smaller. Because if you don't, the air which is kept in the eye for the graft will go back and the graft will detach. Now watch. I pass my 30 gauge needle from one end, do the 4th row pupilloplasty. I'll be bringing this loop out. So you can see there now, I've caught it, brought this haptic out. Once my the suture out, once the loop comes out, I will pass it 4 times, just like how I showed you I was doing the 4th row pupilloplasty. Now, you can see there, once that's done there, next step for me is I have got to tighten it. Now, my idea is not to just make the pupil smaller. I want to make it like a pinhole so that if there is any astigmatism, even that is solved. So here you can see now I'm finalizing it and made it nice. Now my next step is I will check whether the air remains in the anterior chamber or not. So There are three basic procedures of endothelial keratoplasty which you can do. One is called DSEC, where you're taking the stroma, endothelium, and desmase. The second is DMEC, where you're taking only the endothelium and desmase. The problem in DSEC is it's too thick, 80 micron, 100 micron, whatever it is. In DMEC, it is 15 micron, but there's one problem which everybody needs to understand. In a DMEC tissue, I cannot take off the endothelium till the donor is 40 or 50 years of age. Please understand it. This technique called PDEC, which we started in 2013 with Dharmendra Dua, you can do any donor age. And look at how we created. It has endothelium, desmase, and pre-desmase layer. You are looking at the endothelium now. I'm going to create a bubble. Look at that bubble. It does not go to the periphery. All I do is take a knife, enter inside. This air is where you have endothelium, desmase, pre-desmase layer, then the air, then the stroma. So now inject trypan blue inside. Now dissect this graft, load it, inject it inside just like you'll do DMEC. The advantage in PDEC and why we never do PDECs, DSECs, we never do DMECs in Agarwal is we only do PDEC is, one, I use only young donors below 30. Second is I can manipulate this tissue. DMEC tissue I cannot manipulate. So that's the reason why we feel this is the best out of the three techniques available. Once I've done everything, apply the glue, seal everything down. Now the question comes, how did this patient behave? So let's see how this patient behaved. Remember this? This was a pre-operative. 6 times operated. I'm operating 7th time. This is 15 days post-op. And look at the same patient now. Pre-op, post-op, 45 days post-op. And you can see a huge difference from pre-op to post-op. What did we do? We did a glued IOL, we did 4-throw pupillasty, and we did PDEC in this patient. So that's the basic advantage in this case. Now I want to show you something else interesting. Now look at this particular case here. This case, why I wanted to show you was a small pupil. Now look at this. I thought I'll use a pupil expander because it's a small pupil. These are eye rings, which are very good. They are made of polyurethane. And you notice carefully, I'm fixing my eye ring inside the eye, fixing it onto the iris. Once it's there, I thought I'll use trypan blue. Look, it's colored a bit so that I'm using trypan blue, but somehow I still lost my rhexis and I've not noticed it. Now the problem comes when I started my Phaco emulsification. Watch carefully. I'm doing my Phaco emulsification and to my dismay, I get a rent. And with my rent, the nucleus goes down. What to do? Now I'm in a mess. Now at this stage, there's only one thing I can do. I can start praying and hope that nucleus starts coming up. Look at the rent. It has extended because of the tear. At this stage, never do IA because that will create more vitreous complications inside. So all I'm going to do now is fix my trocar cannula. I made my flaps and I'm doing some vitrectomy. And I told you at this stage, I'm also praying a lot, hoping my piece comes up. And luckily for me, the piece started floating up a little bit. Just my luck. And I caught it. Once it is caught, don't leave it. Okay? I'm bringing it up anteriorly and I'm trying to place it above the iris. Now the problem comes, how do I remove this fragment? Because I have an open capsule. If I Phaco now at this stage, the fragment will fall down again. So a technique which we started was called IOL scaffold, in which what we are going to do is, we are going to inject a 3-piece IOL. And any of you can do this technique. Just inject a 3-piece IOL above the iris, but behind the nucleus. So what the IOL does is, it acts like a posterior capsule. In other words, it is a scaffold. Now, this will prevent the fragment from going down. Now, all I do is take the Phaco And before you can say bingo, you can see that nucleus is out. Now, at this stage, I made my sclerotomies. Now my point is I want to take my haptic, which is above the iris, to behind the iris and glue it. But there's a problem here. I did not realize my haptic is getting caught there. You can see on the top there with the eye ring. So now, once it gets stuck there, I caught the haptic, but when I try to pull it in, out, it's just not coming out. And I lost the haptic. Now, I'm trying the second haptic. Remember, one haptic is already lost. If I drop this haptic, I will get an IOL drop also. So I'm now going to catch this haptic with the glued IOL forceps, pull it out. Once that is out, now I go in for the first haptic, which I dropped again with the handshake technique. And you can see there, from one hand to the other, catch the haptic, pull it out. Now, my next step, which I was stuck, was I have to remove the eye ring. But remember, my problem here is I should have dislodged the eye ring from the iris before I pull it out. I did not do that. So now watch carefully. As I'm pulling it out, look carefully again. I've created an iridodialysis. See that? Unnecessary complication. Once I've created my iridodialysis, I have to release this ring back. Now what I'm going to do is I'm going to remove the ring from the iris first. That's what I should have done first. Rather than trying to remove it totally, I'm dislodging it, separating it from the iris. Now my second problem, which is fast starting, is my eye ring is going down. My IOL is also going down. And if you notice carefully, the haptic on this side is also going down. So now my assistant is grabbing this haptic here. I am caught the eye ring here. And you'll be wondering, next time Indonesia will not be calling me again for a lecture after seeing this. So now you see, with great difficulty, I brought my eye ring out. Now I want to bring this eye ring out of the eye. So I'm going to take the injector, bring it out. Remember, my lens is still stuck inside. So I'm coming more anteriorly now to create my sclerotomy so that I can come more anteriorly to get more haptic externalized. Again, I'm going to catch my haptic there and pull it out. So you can see there, I've caught that haptic and now I'm going to pull it out there. Once that's done, now watch, I create my tuck and there the haptic tuck gone inside. But remember, my iridodialysis is still there. I had come more anteriorly, so the posterior sclerotomy, I will just suture it off. It's safer. Now I do my hang back technique. I'll talk to you on this again now. After this, how to fix an iridodialysis repair also and fix this back in place. Complete this case, and you can see this was a very crazy, challenging case which I've created a complication of. And this is post-operative day 1 of the patient. And now I'll show you how the patient looked later on, improved to 6/6 vision also. Now we move on to another case which I wanted to show you here is look at this challenging case also. This patient had an injury. Okay, I am suturing up this corneal wound. Now the cataract is very hard, no doubt, but something has gone through and through into this patient's eye. So now my point is I'm trying to bring this nucleus up anteriorly as much as I can. Once I have done that, look at this. Now I am now going to do a phacoemulsification for this fragment, and I want to remove this nucleus thoroughly. It's a quite hard brown cataract. Once that's done, I fix my trocar cannula because I know something has gone inside also. I already have a rent, not because of me, but because of the injury which has happened to the patient. Now, watch carefully. I'm doing a vitrectomy, and what you see, something is stuck inside. Look at that. It's a large intraocular foreign body, and it has created a retinotomy, and you can see even a retinal detachment there. Now, my next step is, after doing the vitrectomy, I'm now going to catch this foreign body with a forceps. See that? And I'm going to catch it, and I'm going to bring it out. So I've caught the foreign body there, and now I'm going to pull that fellow out. And you can see there, it's a wooden stick. It's a large wooden stick which had gone through and through. Can you imagine the power and speed it has gone through into the eye? Now, once it's done, brought out there, I have to bring it out of the eye. And you can see the size of the intraocular foreign body, how large it is. It's about 11 millimeters. Now, once I'm placing it above the iris, I'm safe. Now, I need to bring it out. So I need to align it so that the long axis of the foreign body is in line with the forceps. And you can see that there, I brought it out there. Once my foreign body is out, now I'm safe. Such a large foreign body, wooden stick, 11 millimeters. All I need to do now is fix my glued IOL in place. So now at this stage, I will now close this sclerotomy. Now I apply my vitrectomy, and I will close up that first retinotomy which was there, which the foreign body had created there. And you can see there, I'm doing my thorough vitrectomy there. I will now also do a glued IOL in this case. So I made my small iridectomy because the large eye, once again in this case, apply the glued IOL technique, which you now know very well how to catch it. Once I have caught this haptic, I will now externalize this haptic. Now, once both haptics are out, here you can see I'm now going to do the second haptic there. And once the second haptic is out, I'm much safer. Now, all I do is tuck my haptics inside. Look at the amount of haptic externalized. It's a lot. So that means this lens will not go anywhere. I've tucked the haptics inside. Now, see how the case is looking for optic capture at this stage, because you can see there is also an iris damage present because of the injury of the intraocular foreign body. So once my haptic is inside, I will now try to assess and see, does this patient need a fourth row pupillasty? See the iris damage which is present there. So this needs a single pass fourth row pupillasty technique, which I'm going to do just now. And once I have done that, you can see there the patient will look much better. So in this particular case, we did a cataract, we did a vitrectomy, we did an intraocular foreign body removal, we did a glued IOL, and we did fourth row pupillasty in one shot and completed this particular case. Now remember, there is a retinotomy inside also. So after this, I also have to seal that retinotomy with endolaser, because I don't want this patient to come back to me with a retinal detachment. So after I drain the subretinal fluid, I will also seal that with endolaser and seal everything down. So here you can see the fluid being removed with the fluid air exchange. I'm doing internal drainage of the subretinal fluid, and I'm applying endolaser, and you can see now, and sealing that retinotomy break permanently. Now I will show you another interesting topic which I wanted to show you is
none of the producers have any financial interest in the products or proceed.
Now look at this particular case here, which I wanted to show you about. This particular technique we just started recently. Now see this patient. This patient has an iridodialysis. Okay. Now look carefully here. The Purkinje image, you see these three dots, they are in the center, but it is falling on the iris. This patient will have less vision because the Purkinje dot, if it's falling here, the pupil should be around this. And this iridodialysis is huge. So now what I'm going to do now is, I'm going to show you a technique called the trocar assisted iridodialysis repair. Now what we have to do is, I'm going to fix this iridodialysis. Very simple technique which I'm going to show all of you. I've got my fluid in the eye. Once my fluid is in the eye, my next step for you is going to be, I've done some vitrectomy, clearing off this mess there. Look at this. I'm taking a trocar right opposite the iridodialysis. This is the iridodialysis. Opposite it, you're fixing a trocar, which is going above the iris. Now you take in your hand a double-armed Prolene needle. It can be a 9-0 double-armed Proly needle. The idea is very simple. I'm going to now take this Proly needle, pass it through the trocar, pass it through the iodialysis defect, bring it out through the sclera. The same thing I'll do on the other side. So you have two double-armed needles. Now pull both. Once you've pulled both, I will tie it up. This hangback technique was started by Michael Snyder. We have modified this into a trocar-assisted iodialysis repair now. The reason is the needle, when it passes through a clear cornea, can get stuck. When it passes through this trocar, it will not get stuck. And now you can see, I'm going to show it to you now. I pass the needle inside. Once the needle is passed, look, on the other side, I'm taking a 30 gauge needle. Now I'll railroad the two. Once I have done that, I will connect the two and bring it out. There's a small groove which I've created here, which will bury the knots for me also on this side. Now the same thing I'm going to do on the other side. So here you can see I'm passing the needle from one end through the cannula. From this side now I'm taking a 30 gauge needle. You can see now this can go through the iris also if you want. There it goes through the iris. Once it goes through the iris there, I will now railroad this with the needle. Now you see I've got two ends of the Proly needle locked into the system there. All I have to do is pull it completely to one side. And here you can see there, I'm pulling it so that everything pulls the whole iodialysis repair. See that? All I have to do is now suture this. Once I have sutured it, I can bury that knot. Now, we also have another thing called the two-fold technique. Now, when you have done this iodialysis repair, remember it, you have pulled the iris to one side, the pupil becomes large. So now at this stage, what you do is do a fourth row pupillasty and bring that pupil down. So here you can see now, I'm bringing this down there and suturing it up. This is the two-fold technique. In other words, I'm combining the iodialysis hangback with the single pass fourth row pupillasty. And you can see that just now, I'm doing this combination procedures so that my pupil, which has become dilated, now becomes normal. And my game plan is simple. Remember that Purkinje image? This Purkinje image will be centered on the center of the pupil. And that's the important point which we should remember it. So now you can see here, I'm now going to see that final case where I'm showing you where my Purkinje image, now look at it, is centered on the pupil. Nicely centered on the pupil. If you want at this stage, you want to enlarge the pupil, you can enlarge it a little bit with the vitrectomy probe. And you can see me doing that just now, a little bit of larger to make it more comfortable. And that's how the patient looks at the end of the day. And now you can all do is glue everything down. So this shows basically this technique which I wanted to show you on how to perform this particular procedure. Now, one more thing which I wanted to show you is this is something which is happening even today in the world. But I thought it's important for you to see it because this is 2020 and we saw this happening in Africa, and we have got about 14 hospitals in Africa, but look carefully. This is an operation theater which they have got there. And I sent my team to actually take a video of the person who's doing this. This is a couching instrument. Look carefully, there is no sterilization worth the name. And as I said, this is happening in 2020. And look carefully what they're doing, how they're penetrating into that eye and dislodging the lens. We are seeing a lot of patients like these. They come with various complications. And subsequently, what we do is we do a glued IOL after removing those nucleus and make them all right. But I thought it's important for you all to see this video also of couching because it's a very bad thing to be seeing happening even in today's world. And look at the patient, the end is aphakic, but there is no sterilization worth the name. This video had won in the ASCRS Film Festival also the award for it. Saying that also, what I thought was we'll show you, I've got some books of ours which are coming out. One is on mastering iris repair, which is coming out next month with by the SLAC team, have published it. And we also have one on glued IOL by SLAC. You can see that it's a full video book on glued IOL. Those who are interested can get this from Helio site or the SLAC site. And we had been talking till now on the Phaco nightmares situation. So I thought we have a book on this, on more Phaco nightmares, once again by the SLAC people also. We thought we will show you this. The last thing which I thought I will just show you here is a case, and then we'll close it. This is a case to show you contraindication of glued IOL. So this will be my last video which I will show you to close up the presentation in exactly 1 hour time. Now this patient was an 84-year-old patient. So look at the contraindication, okay? The patient is 85-year-old lady. That's the first contraindication. Second, she was 20/20 aphakic glasses. That's pretty good actually. She is 20/20 with aphakic glasses, okay? Why should I touch her? I checked her endothelial count. It was only 1,400. See how stupid I am. And then even I went and go ahead to do a glued IOL. But look at the next contraindication. The daughter is an eye surgeon. And that daughter, most important was my wife. And this was my own mother-in-law. She was 85 years old. She had been operated by my mother and was left aphakic. And my point only here is, with all this, I still went ahead. I did a glued IOL for her, as you can see happening right now. And touch wood, she became very good even at 85 and was extremely happy. So basically, I thought I'll end this with this. And I want to thank all of you here at the end for this 1 hour course, which you asked me to talk on various complications. Can you hear me?
Yes, Amar.
Yes.
Awesome.
Udah, finish.
Is there any presentation?
Is there any more?
I thought this is, you asked me to speak for 1 hour, so I spoke for 1 hour.
No.
If you have another to present, go ahead, Amar. Go ahead.
Okay.
We have
We have
all long
unlimited
day
time.
to hear from you.
1 minute. How do I?
Okay. In case you still have like few interesting.
Yeah, we have lots of
please share.
cases. Wait, I'll just show you just now one interesting case just now.
All right. We love to hear from you.
Just tell me if my video is coming.
Okay. Yeah.
The video is coming?
Yes.
Yeah.
Okay. Now watch this case also. Now this particular case, see this case, RK done. You can see that? The patient has got high astigmatism. The problem in radial keratotomy patients is what? When you have a patient with radial keratotomy and they have phaco or cataract done, the refraction changes. The astigmatism is a lot. So you cannot solve these problems so simply. So now, when these patients have unstable corneas, what we decided to do is, we wanted to show how to do a pinhole pupilloplasty, and we published this in the JCRS also. Now look at this case here. The problem, as I told you, in astigmatism is the rays are distorted. When the rays get distorted, you can use a toric IOL, one possibility. You can do a PK, okay? You can also put these pinhole IOLs. The problem with the pinhole IOL is, 1, they need FDA approval. 2, they are costly. 3, it's like a piggyback IOL, okay? But they are very good ones made by Fernando Trindade and other people. But what we thought is, we will do a pupilloplasty. In other words, I'll make the pupil 1.5 millimeters. The idea here is basically this, that when you make the pupil small, you will get an extended depth of focus. That means you can see distance and near without glasses. So now you can see here, I've got fluid in the eye. Now I'm doing this technique called the 4th row pupilloplasty, which I just talked to you about. The idea and advantage of 4th row is, it is so simple You will have patients with PK done, high astigmatism. The patients can't see. Do this pinhole pupillasty and you see the patient immediately will start seeing 6.9 from 6.60. So my idea here is to make that pupil 1.5 millimeters. So here you can see I brought that loop out. I'm going to bring that 4 throws inside the system there. Once I've got 4 throws here, you can see I've done on one side. Now I'll be doing on the other side also. Now look, my idea is very simple like I showed you before. I want the Purkinje image P1 centered onto the pupil. That is very, very important. So idea here is once you have the rays of light going to the center, you will get a clear focus and the patient will start seeing. Remember the problem of diffraction. If I make 1.5, I get it good. But if I make it too small, the rays of light will start diverging and my pinhole effect is gone. So remember a simple pinhole. If you have a patient who cannot see, all you need to do is check on a pinhole. If he's seeing with a pinhole, do a pinhole pupillasty. What is your cost? 1 suture, that's all. Okay, it takes about 10 minutes. Remember angle kappa. The distance between the pupillary axis and the visual axis, the better terminology is chord mu, coined by Daniel Chang and George Waring. Now, what we are trying to do is, in pinhole pupillasty, I'm making my angle kappa nearly 0 so that the visual acuity will improve. Now, once you have done this pupiloplasty, remember, suppose you have made it too small, you can always enlarge it by using the vitrectomy probe. So you can see now, I'm completing this pinhole pupillasty in this patient with RK. And once I have done that, you will see I can also use a vitrectomy probe to enlarge it. So here you can see the final picture. Look at the Purkinje image centered onto the pupil there. I want to make it slightly smaller to make it slightly better. And that's what I'm trying to do. You can do as many 4-throw pupillasties as you want. But the idea is to get a 1.5 millimeter pupil to 2 millimeter pupil. Now, once you have done this pupiloplasty, see what I'm going to do now. Now I'm going to see the Purkinje image. That Purkinje image is looking well centered onto the pupil, but I want to enlarge the pupil a bit. That's why use a vitrectomy probe at this stage and see how the patient looks at the end of the day. So now let's see at the end how this patient looks. Preoperatively, you saw how the patient was looking. Now this is the intraoperative picture, and let's see how the patient looked at the end. So I'm applying some glue now to just seal the clear corneal incisions. Look at the patient now. Preoperatively was 660 vision and postoperatively 6.9. And that is what I wanted to show you on this particular case. Now I want to show you also one more thing which I thought I'll show you is a case. I'll end it with this presentation. Look at this case. This patient had a PCIOL implanted in the anterior chamber. The surgeon had implanted a PCIOL in the AC. Now what I thought was, can I take the same PCIOL, push it back behind the iris? So I'm trying to do a handshake technique and I'm trying to take this haptic which is above the iris to behind the iris. But look carefully, it is stuck so badly. I'm not able to do it. Now I'm trying to make a side port entry, and while making the side port entry, I cut the haptic by mistake. So now what's my mess? My haptic is broken. So now all I have to do is I have to explant this IOL. So now I'm making my scleral tunnel. Look, I'm trying to remove this haptic with 2 hands. It's just not coming. It's stuck so badly. I'm catching it. I'm trying to pull, still not coming. I'm catching, pulling, still not coming. How firmly and how badly it is stuck inside the iris. So now I have no choice. I have to take a vitrectomy probe and cut. That's the only way that haptic can come out of the iris. So I'm trying to cut that iris so that it dislodges from the haptic there. Once it's done there, you can see there, I'm doing that just now. I will now bring this haptic out of the eye. Once my haptic is out, you can see there, I brought it out. Now I will explant this IOL. That's a one-piece non-foldable IOL. But I'm now bringing it out of the eye. Okay. Once I brought it out of the eye, now I take my glued IOL, 3-piece IOL, and I will implant it inside. But remember, the problem which has happened now is, with all this, I've damaged this whole iris also. So once I fix this back inside, both the haptics are externalized. I create my chariot's pocket, tuck it inside. Now I have to repair this iris. There's such a big gap. So what I'm going to do now is, I'm going to do my 4th row pupillasty first, because it's such a huge gap inside the eye. Once I have done that, look, I'll make that pupil a bit smaller. Once it becomes smaller, I'm much better off. It's such a simple technique, the 4th row pupillasty, and I would advise everyone who's watching can go back and perform this surgery. Now I'm doing it on the other side also. Once I've done that, I will do on the top also. But you can notice the idea here is my pupil is coming down to size. But with this, notice there's a large iridiolysis defect on the side, like I showed you. So I'm going to do a trocar assisted technique now, which I just talked to you about, to repair the iridiolysis. So look at this iridiolysis on this side is a large gap which is there. So I'm fixing my trocar opposite it. As I told you, this double armed Proli needle, now I'll pass from one end. The idea here is this Proli needle will not get stuck in the incision at all. I catch it, pass it, coming out through the sclera. Once I've done that, I will now do the same on the other edge also. So once I've got both edges caught, I will now be able to pull it out and suture this thing back, so that my whole iridiolysis defect is solved. Once the first portion is done, now you see I'm passing the second arm of the same Proli needle, and I am now passing it through the sclera. Once it's out, I pulled it. Remember, when you pull like this, the iridiolysis gets corrected, but my pupil gets decentered. So again, I'm going to do a 4th row pupillasty. This is what I was calling you as the two-fold technique. You're combining 4th row and 2-fold and the hangback technique to make it a 2-fold technique. Now look at the portion on the top here. There's a large iridiolysis defect here, because of which, see my pupil, it has gone up. So the Purkinje image is not centered. I need to bring this iridiolysis back on track. Otherwise, this patient will never get 6/9 vision. They'll always have that 660 vision. So again, I fixed my trocar. I'm now going to pass that needle through the trocar, pass through the iris, bring it out through the sclera. And you can see I'm now bringing it out through the sclera. That's one arm. The same thing I'll do in the second arm. Once the second arm comes, I'll be able to now pull. See the second arm now coming through the trocar, through the iris, through the sclera, and pulling it. And now when I pull, you will notice I'm very comfortable in this whole thing there. And you can see there, it is pulled. Now look at it, how nice it is come. And now look at my Purkinje image is nicely well centered. So this is another thing which I wanted to show you in such complicated cases, how we are managing, finally sealing everything down with glue. So I thought I'll now end this presentation here, and I'll stop sharing my screen and ask for anyone, any question and answers which you will have.
Wow, what a presentation. Really cool lecture, Amar. Very amazing videos, sir. Outstanding, outstanding, outstanding. That was beautiful gift for humanity, and beautiful gift for Independence Day of both country, India and Indonesia.
Thank you very much.
Fellow ophthalmologists, now we are approaching the question and answer session. May my interpreter help me to read each question to our guru, Dr. Agarwal. Miss Interpreter, please.
Okay, thank you so much, and good day for all the audiences. And hello, Professor. It's very, very nice It's very awesome that we heard
Amazing.
explanation and presentation from you, especially with so many videos that we can see and learn the material visually. So can we start the questions right now, Professor?
Please. Go ahead.
Right. All right. So this first questions is come from the Q&A box inside our Zoom's application. There is a questions. Is there any condition with the subluxation or dislocation of the lens without trauma or genetic related? For example, for the Marfan or Ehlers-Danlos syndrome, is it high myopia can be one of the risk factor?
See, the problem in these conditions is the zonules are weak. When you have weak zonules, they are progressive conditions. Now, the only point is you have to do something like an intrascleral haptic fixation, either Yamane's technique or Sergio's technique or the glued IOL. We have now publishing in the JCRS a 12-year study. That means post-operative 12 years of glued IOL. And imagine the tilt in a glued IOL is coming to less than 1 degree. I'm talking after 12 years. If I put a normal IOL in a bag, I will get 2-degree tilt. If I put an IOL in the sulcus, that is above the rhexis, I get a 5-degree tilt. Anything above 5 degrees is significant. But in the glued IOL, because I'm fixing it so firmly, I can tuck, untuck, I get less than 1 degree tilt, and I'm talking on a 12-year period, which is huge. This should soon be coming out in the JCRS. It's under review right now. So we are working on it. So my answer to this question is, whenever you have these progressive conditions, don't do endocapsular rings and all. They will all lie on the retina after some time. Okay?
We hope that the participant who answered that has been already got the answer clearly. So this is the next question is still from the Q&A box in our Zoom. This question comes from Dr. Mortazavi Fard, and he is asking about how far from the limbus did you do the sclerotomies in the first case of Marfan syndrome?
Very good question. So what I do is don't go more than 1 millimeter.
Okay.
If you go closer to the limbus, you are better off. That is why I make a small iridectomy. Because when you do 1 millimeter from the limbus, you might hit the iris. You'll create a bleed or an iridiolysis. By making the small iridectomy, you've gone through the iridectomy. So idea is when you come more anteriorly, you'll have more haptic externalized. So more haptic to tuck. That lens can never dislocate in life.
Oh, it's so amazing. And I think it's the next question still has a kind of related with the previously questions. How about the patient with the iridodialysis in cataract surgery? Can you explain about suturing technique? That's what they're asking for.
So what happens is, in an iridodialysis, understand the problem. There is a technique called the hangback technique, which was started by Michael Snyder. You are taking 2 proline needles, okay, which are connected. So once you pass one, you pass the second, then you pull it, suture it up, it tied up. The problem is, when you pass the needle through a clear corneal incision, it can get stuck in the cornea. So what we decided, we did a trocar assisted iridodialysis repair. If you see the video again, you'll realize I'm passing the trocar. Through the trocar, my needle passes. This goes through iris, comes out through sclera. The second needle goes through trocar, goes through iris, pulls out through sclera. When you pull both, it is just like a pulling tug like this, and I tie it up, and my iridodialysis is repaired intact. So this is called the trocar assisted iridodialysis repair.
Okay, thank you so much for the answer. And there is next question, and this is from Dr. Balgis Desi, and he is from Indonesia. Medan, Indonesia. Hello from Medan, Professor Agarwal, and she would like to ask about she needs a kind of your suggestion for Marfan syndrome in pediatric cases. Is it necessary for the IOL implantation?
Now, when you have a Marfan syndrome, or let's say any child, just think about it. If I don't fix an IOL, the child will be wearing thick glasses. You know, when they go to school, how will they play? They want to play games, or a girl wants to do something. It's very tough. There is no harm. We get excellent results with pediatric glued IOLs. Okay. One more question which they're asking me is, does the knot open in fourth row pupillasty? It never will open. Once you do a fourth row, it is like a helical knot. A fourth row never opens. So normally what people do is they pass 3 times, then they'll again go in, bring out, pass 2 times, again they'll go in, pass 1 time. Every time you're going in, your chance of endothelial damage, IOL damage, iris damage is there. Here you've just done one single pass, 4 times, that's it. You can finish the case like that.
Yeah.
Okay.
Actually, we record this for you for practicing. You can play this lecture again and again on YouTube. Yeah.
All right. Thank you so much for the answer. And we have so many questions here, and we will try to accommodate our best. Either the question answer inside the Q&A box, in a chat box, and also from the YouTube channel. So please feel free for the audiences, you still can drop your questions. And this is the next question, Professor. This is from Dr. Made Delta Dwi Hartami. She would like to ask about if possible to change the glue with suture, it means non-absorbable proline or nylon, to fixate the haptic if the insurance, it means public insurance, not available to cover the glue.
Yes, you can use it. My suggestion is the glue, but if you don't have glue, glue is available in Indonesia and every country, but if you don't have, one, you suture the flap well so that there is no leakage. That's all, no problem. You can do it. Only thing, remember, as I told you every time, keep the amount of haptic which is externalized a lot. So that you have a lot of haptic to tuck, but you can suture, no problem. If you're using glue, please remember, you can keep it also for a week also, no problem, frankly. You can use it in 4 or 5 cases.
Thank you, Professor. And the next question, still from the Q&A box, this is from Dr. Robinson Barrientos. He would like to ask, all aphakic patients undergo posterior vitrectomy or core vitrectomy, high-risk retinal detachment in the POP.
See, when you have an aphakic patient, please understand, there is a little bit of risk you will have to accept when a PC rupture happens. But we are not asking you to do a thorough vitrectomy. No, you are doing a little bit of anterior vitrectomy only. You are not going up to the retina to do vitrectomy. But no doubt, if a PC rupture happens, there is a possibility of a detachment. That is not because of the glued IOL or no. It is because of the PC rupture. So when you have a PC rupture and you're doing a vitrectomy, I suggest just do a little bit of vitrectomy, anterior vitrectomy, and that should make it enough.
Okay. Wow. Okay, thank you for the answer, Professor. And a little bit while we move to another question and answers room, now we have one questions from the chat room in our Zooms. This is from Dr. Sri Tatat Fongkul Siri. And there are 2 questions from these audiences. First, how far from the limbus in the flap you use for restrictive? Oh, excuse me. How far from the limbus in the flap you use for retrieve the haptic out? And this is for the procedure of glue fixation.
I told you before, even the same question, we do 1 millimeter from the limbus.
Okay.
1 millimeter from the limbus. Large eyes, you stick 1 millimeter from the limbus. But as I said, if you necessary, you can make a small iridectomy also so that you go through the iris.
See. All right. Thank you. And the next, still from the same person, what is the target power of the IOL for intrascleral fixation?
Same IOL. Look, the IOL is in the same position where your normal IOL is placed. So let's say if I was to calculate a 20 diopter IOL normally in the IOL, I don't change my IOL. I use the same IOL power in the glued IOL also. So same power.
Okay, thank you so much, Professor. And we have audience and with very good questions. This is from Professor Alicia Chima. I'm sorry if I mistaken to mention your name.
From Pakistan.
Yeah, she is a professor of ophthalmology at GPMC Karachi, Pakistan. And she would like to ask you about, do you see any retinal tears later on in the few months of the post-op? It's related about the procedure in which the nucleus was retrieved and the IOL haptics graft.
Whenever you have, these are all worst case scenarios. First, let's understand it. Any complications like PC ruptures, dropped nucleus, dropped IOLs are complications. So you can get, what we do is we examine the retina post-operatively carefully for 1 month post-operatively.
Okay.
And if some lesion is there, we will seal it. But it's by and large not because of the glued IOL. These are by and large complication cases because of the PC rupture, vitreous loss, etc. So if there is a break, I suggest do an indirect and seal it.
Yeah.
Okay.
No, not by glued IOL.
It's not because of the glued IOL it's happening.
Yeah.
Correct.
All right.
Please understand.
And there are two questions more, and it's actually inside our chat box. But seems here that you have been answered it. This is from Dennis Kong. What is the risk of knot slippage in the 4-throw pupilloplasty technique? And I think you already answered here.
Yes, the knot will never open up.
Okay.
Remember one thing, pass 1, 2, 3, 4 in the same direction. You should not do 1, 2 and then 2 in the reverse direction, then it becomes 0.
Yeah.
Sometimes, suppose you're doing 1, 2, 3 and you've forgotten whether I've done 4 or not, do an extra 5, nothing wrong. But
Okay.
don't do less than 4.
Yes, yes. All right. Thank you. And I think, I don't know, perhaps you still want to explain more still from the chat box from Dr. Jitendra Kumar. Is any post-op complaint after pupilloplasty like recurrent iritis? You already answered that. No pain after.
There will be no pain. There's no uveitis, no iritis after pupilloplasty. See, the advantage in 4-throw pupilloplasty is very simple for anyone to do. So what happens is everybody can start moving into this. Rather than doing more complicated procedures, you know, the 4-throw is so simple and it gives instantaneous results.
All right. Okay. Thank you so much. We move back to the Q&A box from the Zooms. This is from Dr. Andreas Surya Anugrah, ophthalmologist. And there are three questions, but I will mention one by one. First, how to make the scaffold, excuse me?
Scaffold.
Oh, scaffold pocket. How to make the scaffold pocket?
See, for scaffold, it's not a pocket. Very simple. Suppose I've got a PC rupture. I've got a nucleus inside the eye. Now, what happens is, bring my nucleus above the iris. Now, implant my IOL, 3-piece IOL, above the iris, but behind the nucleus. So, my IOL now acts like a scaffold. In other words, my nucleus cannot fall down. It's like a posterior capsule I've created. Now, I go in with a Phaco probe, and I can emulsify that nucleus and complete the case. If I did not implant an IOL before, what will happen is when I go to emulsify the nucleus, my fragment will go down.
Yeah.
So that is called the IOL scaffold technique.
Okay, okay. And there are two more questions, and I think it's related, so I will mention in the same time. First, in a trocar-assisted pupilloplasty for iridodialysis, how far or how millimeter should we insert the needle at the iris from the edge of the pupil? And in every pupilloplasty, should we always do vitrectomy prior to trocar-assisted pupilloplasty? Thank you.
If there is vitreous, then you do vitrectomy. Otherwise, it is not needed. Okay. Second, how far I should go? Go approximately 1 millimeter from the limbus again here. If you're approximately 1.5 millimeters from the limbus, the iris suturing will be correct on track. You will have no problem. So stick to about 1 to 1.5 millimeters from the limbus.
Okay.
Okay.
Thank you, Professor. And let's move to the live chat from YouTube. So I believe the audiences in the YouTube channel are waiting also about answering the questions. First question from the YouTube live chat is from Dr. Disa Rani. How is the iridectomy made, sir? And what is the instrument you used?
We are using a simple vitrectomy probe. The same vitrectomy probe, I just pass it inside the eye and I'm using that to make the iridectomy. That's all. The same vitrectomy probe can be used to create the iridectomy also.
Okay, and next question, it's from Dr. Sudesh Subedi. Thanks for the nice presentation, and he wants to ask about what is the risk of vitreous traction and the retinal tear while rotating of subluxated MF IOL.
Okay, when you are doing a multifocal IOL or any subluxated IOL, remember that if you see the video, I catch the IOL, I did not externalize. I first did a vitrectomy around it so that the additions between the IOL and the vitreous are cut. Once that is cut, then I will externalize it. So my chances of any vitreous traction are reduced drastically.
Okay. All right. Thank you. Still from the live on the YouTube. This is from Dr. Sneha Karkera. There are two questions, and I think it's related. About the rise IOF post PKP.
Post photokeratectomy.
Okay. About the rise IOF post photokeratectomy. Okay. Or the silicone oil that have already damaged the TM. So with pupilloplasty, can long-term IOP control be achieved? And then can a trial of a myotics TBE given to the patients with secondary IOP rise prior to pupilloplasty as both work on opening the angles?
Okay, it's a good question. Now let's understand one thing. If I put myotics, it won't work because there is synechiae. The iris is stuck. By putting pupil drops, it won't work. I have to break those synechiae and I have to bring it down. Second story, what if trabecular meshwork is damaged? It might be damaged. Whatever it is, I need only 25% of the trabecular meshwork to be open. Okay? If 25% is open, I'm through. Third thing is, let us suppose the pressure was 50 and it comes down to normal, you're good. If it was 40, 50 and it comes down to, let's say, 30, then you put drops, medication, still you're much better off. So some cases, we will do valves if the trabecular meshwork is very badly damaged. But most of the cases, we can do very comfortably with fourth-row pupilloplasty itself.
Okay. Very, very clear answer. And next, this is a question from Dr. Ananda Laksmi Subramanian. And sir, how do we manage if there is a hyphema during the SFTP technique?
SF?
SFTP procedure? I think you have like, what's the SFT?
Okay, in the pupilloplasty, understood.
Already
okay, the question is, how will you manage the hyphema if the pupilloplasty, fourth-row pupilloplasty is done? Very simple. That is why I said I always fix a trocar cannula. If you play this game with viscoelastic, when you pull on the iris, bleeding will happen. That blood will not go. It will be troublesome for you. When you fix a trocar, fluid is all the time flowing inside the eye. When bleeding starts, the blood will just start flowing out. So my question is, an answer for your question is, fix a trocar cannula so that fluid always moves. The fluid will push off the blood and you'll be very safe.
All right. Very clear. And do you want to read this, Mr. Moderator? This is from Sachin Segal.
Oh, yeah.
Okay. Another question is from Dr. Sachin Segal. It's still from the live chat in YouTube. Anything special, Professor, in techniques while sealing a retinotomy post-pupilloplasty in small pupil with bad scarred cornea?
Sorry, repeat that question, please.
Anything special in techniques while sealing the retinotomy post-pupilloplasty in small pupil with bad scarred cornea?
What happens in these cases is this. When you have a small pupil, if you are doing fourth row pupiloplasty, the pupil will dilate a bit. If you do techniques like encerclage, it will not dilate at all. That's why I suggest do fourth row pupiloplasty. The pupil will dilate a little bit. You can see enough through the fundus for examination. But let us give an example. You've done this pinhole pupiloplasty and the patient develops a retinal detachment. In such cases, what I suggest to people is just take a YAG laser and shoot. The pupil will dilate fully and you can treat the patient. So these patients can be treated very comfortably with laser through small pupils. Also, you can go through them, no problems.
Oh,
Okay.
okay.
Thank you so much.
Thank you so much, Professor. And let's back to our Q&A box in the Zoom's application.
There are so many questions, Professor.
Please be patient. We hope that you
Do you mind?
Yes, yes.
All right. Okay, the next question is, how long is the learning curve for the SPFT procedure that we just discussed before?
It is very easy. To be honest to you, the fourth row pupiloplasty, single pass fourth row pupiloplasty or SFT is very simple. All you need to do is, if you see the videos which I've shown, if you follow that, take a proline needle, you can do it like that. Anybody will be able to do it. So it's very simple. The learning curve is not much at all. In one case, even you will be able to learn the technique very well.
Okay, and this participant, he's not mentioned his name, but he's also waiting for your books. You said like that. And I think another question is from Dr. Elo Rohmawati.
Yeah.
She's an ophthalmologist from Indonesia as well. And she would like to know where she can get assisting trocar for a positional iridodialysis.
What simple is, you can contact Alcon or Epsilon companies. Any of these companies, they all have trocars, Bosch and Lomb, and they will be able to give it to you.
All right. Okay. I hope it will help. And another question is, what is the needle and the forceps that actually needed for the SFPT procedure?
Proline suture needle. All you need is a proline needle. They are available in the market. They can come in 9-0 or 10-0 available.
Okay,
you choose any one, whichever is available, and you can use them.
Okay. Okay. Thank you so much. And another question is, how will you be able to do the AVF procedure in glaucomatous patients after the pinhole pupilloplasty?
The what procedure?
Visual filter.
Filtering procedure. Well, if you need to do, you can do a filtering procedure.
Glaucomatous patient after pupilloplasty.
No problem. You can easily do it. You don't need to do it. If you done a fourth row pupiloplasty and made the angle open, you will not need to do a valve procedure. But if you need to do a valve, you can easily do it. It's very easy.
Okay. All right. Thank you so much. And actually, just kind of trying to more understanding about the contraindication. This attendee really wants you to stress and explain more about the contraindication for the glued IOL in your mother-in-law case you told before.
Actually, that was like what I wanted to tell you in that condition was, look, it was my own mother-in-law. But with all these problems, I still went ahead and did glued IOL because I was so confident the glued IOL is so good. If you ask me, glued IOL does not have any contraindications, except one. If by chance somebody has a ciliary staphyloma all around, you can't fix a intrascleral haptic fixation. Otherwise, today, if I have any time, any patient with these complicated cases, we only do glued IOL in Agarwal Hospital because it's so safe and extremely reliable.
Okay, thank you so much, Professor. And let's we know about the questions from Kathmandu, Nepal. This is from Dr. Sabindaka. Namaste. Good morning, and he would like to know about if you have ever faced in post-op period following dilatation a case of optic capture by iris in any patient you operated by the glued IOL with the anterior sclerotomy.
Yes, you will get an optic capture. So that's why on table, I tell people, fix the optic capture on spot. But let's suppose you have not done it. Post-operatively, patient comes to you with an optic capture. Just take him back to the OR and do a fourth pupillasty and make him all right.
Okay. And if there is a continuing question, is it necessary that if there is no optic capture on the table, none will happen in the future, dilatation and constriction, right? And what is the IOL power modification you usually do in these cases? Thank you.
IOL modification I don't use. I use the same IOL power which was fixed for the normal patient. Let's say, as I told you before, it was 20 diopter IOL I had fixed. I will use the same 20 diopter IOL. By and large, if you don't have an optic capture on table, you will not have it post-operatively. But let's suppose it comes post-operatively. Again, you will have to just go back and do a fourth row pupillasty, which takes 5 minutes, and make the patient all right. But don't leave an optic capture like that. Fix it back.
11 more questions, Professor.
Sure.
Are you okay?
I'm okay.
Okay.
It seems like all of our participants so
Enthusiastic.
yeah, because you explain with so
Yeah.
all right.
Passionate.
It's very passionate. So the next question is from they see from your video about the repair of the iridodialysis with the trocar assisted hangback technique. Is it more easier to insert the double arm needle through a new corneal incision than through a trocar? Does using a trocar have more advantage than using a corneal incision?
Huge difference. Huge difference.
Huge difference.
Many times, I tell you what, when I had only corneal incision, I'm passing it through cornea. Many times it goes through cornea. It does not go into the incision. Then I'm stuck. Again, I have to cut the suture, remove it. When I pass it through trocar, it's 2 seconds. It just goes through like in a second because there's nowhere else it can go. And you can direct it. The cannula directs the needle exactly where you want it. Otherwise, the needle will be moving so fast. So I suggest to everyone, please use the trocar assisted iridodialysis technique. You will not do anything else once you start that.
All right.
Okay, all right.
Very, very clear.
So next question is still from the anonymous attendee. What effect could possibly happen when you do pupilloplasty and the pupil dilate in dim room, or after that pupil is not working because of the hecting?
See, this will not dilate too much. So once you're done pupilloplasty, you have to understand one thing. The patient's visual acuity will actually improve. The second advantage in pinhole pupilloplasty is the patient will start seeing distance and near without glasses. They get an extended depth of focus. So in other words, the advantage in the pinhole pupilloplasty is they will start seeing distance and near, and they don't need presbyopic glasses also.
Okay, very good answer. And still about the pupilloplasty, is there any risk of the visual field deterioration after pinhole pupilloplasty on a surgical induced high astigmatism? And how to avoid?
We tested the patient on the perimeters and there is no field defect. Now, one more thing is there. We also tested on mesopic, photopic vision. And this is also under review right now with the Journal of Refractive Surgery. We have done this work with Jack Holliday, and we got a special machine called the Clinical Trial Suite, which is FDA approved from the United States. I also want to tell you, we have a new product called the AVA, which is an advanced vision analyzer. This is a special one, which is a virtual reality headset for fieldless testing. And with the corona time, you don't need to fix autoperimeters. With this AVA or advanced vision analyzer, the patient gets this fixed and the field defects are checked, and there are no field defects in gluteals or in pinhole pupillasties. So don't worry about it at all.
So much, Professor. And the next question is there any risk of visual, this is the next question from the same attendee about how to avoid the iris bleeding during the pupilloplasty?
I said that answer before. Simple way is to fix a trocar infusion cannula inside the eye, AC maintainer, so that the fluid will keep on pushing the blood out.
Yeah,
Okay. Okay.
continuous irrigating.
Correct. Correct.
Yeah.
All right. And the next question is, if the infusion cannula is in AC in some videos and in some at pars plana, how to decide on the placement level? This question is from Dr. Tariq Ahmed.
See, I'm a retinal surgeon, so for me, I'm very comfortable whether it is pars plana or in the above the iris. We designed this trocar AC maintainer, we designed purposely to be above the iris for people who are anterior segment surgeons. Because the fear is when you go to the pars plana, you are not confident as an anterior segment surgeon. With it going in a trocar AC maintainer, you are very safe. My suggestion to people is all of you use a trocar AC maintainer, which is above the iris, absolutely safe. You will not have any fear.
Okay. And this is from Dr. David Murphy. He would like to ask about how big a bite is optimal for 4-throw pupilloplasty.
Come again?
How big a bite is optimal for 4-throw pupilloplasty?
How big a bite is optimal for through pupilloplasty?
I'll tell you 1 minute.
Yeah.
So basically, when we are doing a 4-throw pupilloplasty, catch the iris, pass it so that there's a little bit of iris tissue caught in it, so that when you pull, it should not tear away. That's all the idea is. That's all. One more question is there I'm seeing here is about sutured IOL. Okay. I don't advise people to do sutured IOL. We do only glued IOL. I tell you what, we have done a publication in one of the journals, if you see, where we have shown sutured IOLs or iris sutured IOLs, the lens will move a bit. The advantage in the glued IOL is it remains rock steady. I give you a small example. Take a camera, break the lens of the camera, suture the lens back to the camera with sutures and take a photograph. You cannot take a photograph. You throw the camera because the picture will move. When you take the lens camera and fix it to the body of the lens with a glue, the camera body and the lens will move in one. That is why these glued IOL patients are so happy, because when they see, there's no movement of the image.
Right.
This is the question from Dr. Lee. How many clock hours can a single stitch 4-throw pupilloplasty can open the drainage angle? Does this vary with different degree of SMEC?
I've shown that in the video. If you see, there's a nomogram. If you have more than 270 degrees, you might have to do 6-point fixation. If you have less than that, you can make to do only 4-point fixation. So depending upon the density of the peripheral anterior SMEC, you can do more. Okay?
Yeah, okay. The next question will be from Dr. Manohar Mehta. In case of we want to remove glued IOL, how to do, sir?
If you want to remove a glued IOL, we have done that in some cases also. Make a scleral tunnel, catch the haptic, bring it out of the tunnel, and just pull it out. Make a scleral tunnel and pull it out. It's very easy.
Okay. And the next question from Dr. David Murphy again. Do you favor a triangle tip or spatulated tip needle for iris suturing? Pass through the cornea, pass through iris without cutting iris, or oversized hole through iris?
If you use a 30 gauge needle, you will not create that hole. In the beginning, I was using a 26 gauge needle. Then I shifted to a 30 gauge needle. The 30 gauge is very small. So it's very safe and comfortable for the iris.
All right. And how long the glue IOL will last?
Forever, till the end of life. We have now got a 12-year follow-up.
Okay.
12 years. That is the longest follow-up which we have till now. And I told you the tilt is only less than 1 degree. So by and large, these lenses remain till the end of life.
Okay, the next question from Dr. Ahmed Masrua. In the last video, was it possible to just leave the cut haptic inside the eye and not to explain it?
See, I don't want to leave a haptic inside. One, that haptic will rub somewhere. It can rub the endothelium tomorrow. It can move. It can fall down. Something happens. So when I'm inside, I might as well remove that haptic which is broken. I don't, by and large, would like to leave a broken haptic that is protruding and sharp inside the eye, you know. So I would like to remove that off.
And the question from Dr. Dennis Kong. What is the risk of not slippage in the 4 through pupilloplasty technique?
I told before also, it does not open at all. There will be no slippage at all.
All right. Thank you, Professor. And dear Professor Agarwal, the question from Dr. Kantika Prinadita. What the type of IOL can we use for glue IOL? Do we have used 3-piece IOL, and what type of glue did you use? Thank you.
The lens should be 3-piece. Use an acrylic hydrophobic IOL. That's why I prefer the company of J&J or AMO lens, which is fantastic haptic and a very good lens to use. The glue you can use is from Tissel Baxter. It is available around the world, in Indonesia, everywhere in the world. It's a multinational company. Just have to type the name Baxter and Tissel, and you will be able to get that glue.
All right. How much the bottle height ideally to use anterior chamber maintenance?
Pardon?
How much the bottle height ideally?
Oh, normal height. You can always reduce it or increase the height depending on it. The idea should be basically that your fluid is well formed in the anterior chamber.
Do you perform injection of intracameral antibiotic to give to the patient?
No, I don't give.
Okay. And what formula do you use to compute scleral fixation IOL power? What is the target of refraction? This is the question.
I keep it like normal, like your normal IOL procedure, same thing. IOL masters we use, and exactly same like what I will do in a normal IOL.
All right.
But if I'm doing a child, I make one eye emmetropic, the other eye I make slightly myopic, so that the child is able to see and distance and near without glasses.
Okay.
Thank you.
Thank you so much, Professor. And there are next questions. First, how severe the extent of the pupil damage that it still can be repaired with the 4-throw pupilloplasty technique? And the second question is, after the pupilloplasty stitch was done near the pupil margin, is the pupil still can be dilated, especially if we need to dilate the pupil to evaluate the posterior segment after the surgery or pre-existing retinal disease?
See, that's why I said, I showed you the video also where you can dilate the pupil a bit after 4-throw pupilloplasty. So you can dilate. You can examine the fundus. So I'm not saying it will become 11 millimeters, but enough for us to see the fundus examination.
Yeah.
So you can do it.
Okay, thank you. And this is from George Soswan. Do you use multifocal IOL for glued IOL with the normal posterior pole? Thank you.
See, we will use glued IOL multifocal if the patient needed it. If they don't require it, you can put a monofocal IOL. But there's no harm in also doing a multifocal glued IOL.
Okay, thank you, Professor. It's a short question. This is from Dr. Nur Cahya Ardian Bramanta. He would like to know about, is there any intracameral antibiotic that you give to the patient?
No, we don't use.
Okay. You don't use. All right, thank you. And this is from Dr. Sahab Mohammed Said. Oh, it's just like want to greet you. And then next questions. Could you explain more about the virtual reality perimetry?
Okay.
Is it as effective as Humphrey perimetry? And how much is the cost? This is a question from Dr. Teguh Setiawan.
Okay. Now, this is called the Advanced Vision Analyzer. We have designed this specially, made by this company called LISR. The advantage is very simple. One is the cost is, compared to a Humphrey autoperimeter, is 1/4 the cost. Second thing is, on a comparison between the Humphrey autoperimeter and the Advanced Vision Analyzer, it is absolutely no difference at all. But the big thing is, it is just like a virtual reality. So all I have to do is I fix it inside my headset like this. Today with Corona, you don't want this big bowl with a headset, with a chin rest and all coming in. This is just simple. It is portable. So it's very comfortable to use. If anybody wants, you can contact me. I can connect you to the companies of LISR and they can contact you then after that. So my email, just to note, everyone who's on this can note it, my email down, aehl19c@gmail.com. I repeat it, aehl19c@gmail.com, and we can send you. But the advantage basically of the virtual autoperimeter is it's mobile, it is cheap, gives excellent results, and it is also got US FDA approval. So that's the big thing.
Okay. Oh, it's very awesome. Okay, and the next question coming from Dr. Francis Raymond Castor. What the formula do you use to compute what is the target of the refraction?
That's what I repeated it. It's the same as what I do for normal IOLs.
Yeah.
It's the next question.
Let's see, maybe the second last question. If we already use Yamane technique and it's failed, IOL decenter, can we use the same IOL for glued IOL? Because the haptic had been sorted by Yamane technique.
No, that lens will have to come out because see, in Yamane, they have created a bulb.
Okay.
When the bulb is there, you see, you've shortened it. So there's a problem there. The Shin Yamane is a very good technique. The reason why I'm not using it that much is there's a bit of tilt I see in Yamane. That's why we are doing the glued IOLs. As I said, in the glued IOL I showed you just now, we get less than 1 degree tilt. So if you have done Yamane, my suggestion to you is explant that IOL and fix another lens inside and do a glued IOL.
Do you can explain about the effect of the glued IOL in scleral pocket to the limbal stem cell, Professor?
In limbal?
Yes, limbal stem cell.
So there's no problem. It does not damage anything in the limbal stem cells at all.
All right. Do you have any technique to do pupilloplasty in dilated atonic pupil?
I use the photopupiloplasty.
All right. I think you have answered all questions, more than 30 questions.
Thank you very much. I wish
Thank
you all
so much. Thank you so much.
Wish you all the best, and all the delegates, I want to thank you.
Professor, one more please.
Yeah.
It's just your
Just wondering how to implant a multifocal IOL, which I believe is a single piece IOL, wherein you mentioned 3-piece IOL as a...
No, you need 3-piece IOL. You can't do this with single piece. You need a 3-piece IOL. That's why I said you get it from J&J. Only J&J or AMO have got a 3-piece multifocal IOL.
All right. It was clear. Thank you so much, Professor.
I want to thank everyone here.
Yeah.
Gede and Ruth and everyone here for thanking me, inviting me for this lovely...
Professor?
Excuse me, Professor.
Yes?
We are sorry.
We would like to make everyone here pleasure, and there are like 2 more questions from the YouTube channel.
YouTube.
Is it okay for you,
Yes,
Professor?
please.
Okay. First, this is a question from Dr. Heri Purwoko. It's about before and after the maneuver and the intervention. Before and after you are perform all the cases. Are you doing the preventive retinal barrage laser?
No, we don't do. Not needed at all.
All right, thank you. And the next is, Excuse me. This is from Rajasri Das, Dr. Rajasri Das, from which company of the India that she can get the Prolene with the long needle?
I think it's Ethicon.
Oh, okay.
Ethicon, all right, all right.
Okay, and this is about for a larger iridodialysis. Do we need any additional procedure?
No, if you have a large iridodialysis, you do one, then do multiple, do 2-3 areas.
Right.
That's all.
Okay, that's all. And the last is from Dr. Rabindra Prasad. Do you also implant artificial iris if there is extensive iridodialysis?
Yes.
We also implant artificial.
We have an aniridia IOL also there. An aniridia IOL is an IOL which has got an artificial iris inbuilt in it. So in that case, I will use an artificial iris itself, which has the artificial iris and the IOL with it together to make it all right. If there is no iris at all, then I cannot fix it with pupilloplasty, in which case I use an aniridia IOL.
All right, thank you. It is really last question. It's still from Dr. Heri Purwoko. Do you have any notes about the complication of the post-op, like the macular edema, like a kind of retinal tear or retinal detachment, a vitreous hemorrhage, choroidal hemorrhage, and etc.? And also, do you get the surgery complications documented related that it's a very, techniques?
We have published this in the JCRS also, and our new publication is coming out now soon, should be soon coming out, with a 12-year study showing the various complications and results after a 12-year study of gluteals. It will be soon coming out.
Okay, thank you so much, because we believe that learning from the experience from the experts is very important. Thank you so much.
Thank you very much.
Professor.
Wish you all the best once again. God bless everyone. Thank you very much.
So fellow ophthalmologists, that's all folks. We learn a lot at this moment. This is very excellent to handle super challenging nightmares. So please be prepared. We all can play this lecture again and again on YouTube. We record this for you for practicing. Please pay attention to detail. Do practice a lot and do more practice, because practice makes perfect. And practice makes the impossible possible. Thank you, Agarwal.
Thank you. Bye-bye.
Hospital.
Bye-bye.
SMEC Group. Thank you, Chendo. Thank you, Meiji. Thank you, all committee. Thank you, Miss Interpreter. And thank you, all friends from around the world, all very amazing participants.
Wish everybody around the world bye-bye. Thank you very much.
Yeah, thank you so much. Hold on. Please send our regard to your family. Thank you so much, Professor Agarwal, for this memorable.
Thank you very much.
Jaya He.
Thank you. Bye-bye.
What a presentation, Amar. Outstanding.
Thank you.
That is
Thank you.
really awesome. Thank you so much. Thank you so much. Bye-bye. And everyone, see you on the next 1 hour with the Maestro. Thank you, my beloved friend from all around the planet. Stay healthy, stay wealthy, and stay happy, everybody. Happy Independence Day for India, and happy Independence Day as well for Indonesia. Thank you so much. Thank you, everybody. Assalamualaikum warahmatullahi wabarakatuh. Dan Ruth, now time is yours. Thank you so much.
We have arrived at the end of this webinar. We really hope our webinar today will enrich the knowledge about glute IOL and other techniques Professor Agarwal has taught in cataract surgery. We would like to appreciate once again for Sabang Merauke Eye Center, Dr. Agarwal's Eye Hospital, Chendo, and Meiji for supporting this event. We also want to express our deepest gratitude to Professor Amar Agarwal as the speaker for the amazing lecture, Dr. Gede Pardianto as the moderator, and all participants for the enthusiasm in this webinar. We would like to inform you that your e-certificate will be sent to your email after this webinar. Thank you for your attention, and see you again at another series of 1 Hour with the Maestro webinar. Happy Independence Day for Indonesia and India. Have a good day.
If you're serious about your business, you need to build Zoom.